officially.
Oh my god. Craziness. Oh,
Okay.
you went straight to the page that has the thing on it. Okay, I'm in a different screen entirely, but that's fine.
I'm just showing what you're screen sharing for me.
No, I know. I'm not showing that window. Right now it's just the two of us, but it's fine.
Oh, okay. Professional, medical professionals, BTW. All right. Yes.
Yeah, we're not.
Hello, everybody.
Hi.
We're doing board review today, except it's not my board review. It's psych board review.
Yeah.
I have zero expectations for what's going to happen today. I don't consider myself an expert in psychiatry at all. But it is like something that we have to deal with in the hospital as hospitalists. Patients do have psychiatric complications that usually complicate their recovery and their treatment. So we usually end up working in tandem with them regardless, as much as we try to avoid them. Like ends up being a very real component of our daily. So I'm joined today by Lev, if you want to introduce yourself.
Hi everyone, I'm Lev. Relevant to today's conversation, I'm a psychiatrist in my daily life. And yeah, I stream and stuff. I don't have a good intro. I don't know. I do singing and stuff. Hi. I'm very excited actually because I think you'll do better on this than I would. The funny thing about what you just said though is that because of the attitude people typically have about psychiatrists, I just unconsciously insert the word unfortunately at the end of everything that you said. Like I have to deal with psychiatry in the hospital, unfortunately. Our patients often have psychiatric issues, unfortunately. I'm sorry. That's my unconscious bias. How hard is it to become a board-certified psychiatrist? As hard as becoming a board-certified... Well... No, I'm not gonna say it's as hard as becoming a board-certified anything, but it's as hard as becoming a doctor. You just gotta go to medical school.
I will say I don't know anybody that had to soap out of psychiatry. Like match stats wise, I think everybody who applies to psychiatry ends up getting into psychiatry.
Yeah, like it's not that as competitive. It's getting more competitive, I think, because the lifestyle is pretty good and the stigma around psychiatry is a lot less, which used to be what kept a lot of people from applying, but it's definitely not as competitive as the big four.
Wait, what's the big four?
Oh, the road specialties?
Oh, road.
Yeah.
Okay.
Yeah.
I was like, wait, I've never heard of big four. Yeah, so usually like when you're talking about specialties, in terms of like lifestyle and compensation, right? Obviously compensation wise, shit like neurosurgery or cardiothoracic surgery is going to be making the most money for you. But like obviously you're going to spend a lot of time in training for that, and your lifestyle is probably not going to be that great just because you're on call doing these complex emergency surgeries at like 3 a.m.
Yeah.
And you earn and work as hard as you want and make as much money as you want, but do you have the time to spend that money is another thing. When you consider the lifestyle specialties, the road specialties, ROAD, medical students kind of think of these as like the golden, halfway point between making a good amount of money and having a good lifestyle. So radiology, ophthalmology, anesthesia, and dermatology are like the most competitive specialties that are not full-on surgical subspecialties, but still get you like a decent amount of money, like $400K plus a year, while also working probably like a 40 to 50 hour work week. And that is very attractive to a lot of people. That's not to say that internal medicine and psych can't push 400, but definitely like in my case, if I wanted to make 400, I would have to grind, pretty hard. Working 26 weeks of the year as a hospitalist, 7 on, 7 off, I would probably peak at like 325, 350. So if I wanted to work maybe like 22 shifts a month instead of 16, 17 shifts a month, I could probably do 400, but then again, you know, is that worth it, right? Like, would I want to push myself working that much just to make like an extra 50K a year? But I mean, yeah, psychiatry, my cousin is doing child psych over at Mass Gen.
Oh my gosh, okay.
I mean, to be honest, like, actually, okay, the lore is I actually wanted to do psychiatry because we went to medical school together. So I actually
Because you're cool. See, I knew I liked you.
I was actually part of our school's Klingenstein Child and Adolescent Psych Fellowship program, and I had like mentors like throughout med school to try to, you know, push me into child and adolescent psych, because low-key child and adolescent psych makes a lot of money.
They do. They make the most
than,
money,
like,
yeah.
forensic psych, like, or psych
forensic,
or anything,
Jerry,
you know?
or anything else.
Yeah. The reality is, you can be a psychiatrist in Manhattan, you know, handing out like ADHD medications to worried New York socialite parents and their children. But that's what society decides to reward, right?
Yeah.
So,
There's also a big demand in Manhattan for addiction psychiatrists.
Oh, that too.
They can make a lot of money.
That's what Pax Prentice is there for. Where was I going with this? I don't know. I was just like, what did I do? I think my third year I did my psych rotation. I was doing ED consult psych service. And then I was like, yeah, I don't want to do this anymore.
No.
Well, I mean,
that was the mistake. That's the worst.
It was hard
in my opinion. That's
like,
the worst setting for
a lot of the patients we would see is just like these poor like undergrads from like the undergrad campus. Like, they would just make like a suicidal gesture or a suicidal threat, and then, you know, their friends don't know any better, so they call on campus police, and then these like 18-year-old, 19-year-olds are just sitting in the ED all night. And probably have no like suicidal intent with plan, but you know, we have to keep them here and evaluate them. And I just felt bad. I was like, damn, like this is all I'm doing for 4 weeks.
I have strong feelings about the ED, and they are negative, unfortunately. I love everyone I love everyone who works in the ED so that I don't have to. I don't like going there. So I mean, the ED, it just sucks, right? Because it's like, either they don't need to be there, in which case they're upset, and then you feel bad because you're like, I don't want to keep you, but I do have to have an hour-long conversation with you. Or they do need to be there, in which case they're having one of the worst days of their lives, and you're not really in a position to like actually be able to do anything to help in that moment, because it's often like 3 a.m, and the most you can do is like, we'll talk more tomorrow. Not me. I will be sleeping, but someone else will talk with you more tomorrow. And then you never get to see them get better. So, I don't know. That's why I don't like it.
So what are your plans after graduation? Like, what fields, what job market do you plan on entering?
Oh, I'm so excited. I'm going to be doing mostly private practice, like outpatient psychiatry. Well, I'll take insurance. I only want to take insurance. I don't really want to do cash only, just because I have moral oppositions to that, personally speaking. Not to say that no one should do that. I understand why people do, but I prefer to be someone who takes insurance. And I love doing therapy. Therapy's like my thing. I really, really love like combining multiple modalities of therapy, like being able to do like dynamic or analytic therapy in someone and also do CBT with them, because like they need both. I've had some like really good success. I don't know. I'm writing a paper about it right now. That's why I'm thinking about it. But yeah.
CBT stands for cognitive behavioral therapy, by the way.
Oh, sorry.
Because we're on Twitch.
I forgot
think that
about
means
that.
Something else.
I had to learn what the other meaning of that was on stream. Because I'm so used to it. I just start saying CBT. And the problem is also, the first time I started talking about CBT on stream, it was in the context of talking about CBT treatment for OCD, obsessive compulsive disorder. And the CBT treatment for OCD is also an unfortunate acronym, ERP, which I also didn't know. That's
so funny.
So I was like, I was so happy because I have this patient I've had a really fun experience being able to do ERP CBT and that sentence just did not make sense to anyone else except for me, apparently. So, ERP is exposure and response prevention. It's like exposure therapy for
erotic
OCD.
role playing.
I didn't know that one. Someone tried to explain role play, and I was like, oh, like online, like email or e-dating? No. No, not online role play, erotic role play. And I was like, geez, what kind of person do you guys think I am, you know?
CNC stands for computer numerical control. I thought that was like a machining kind of thing, like
what else
like
does
making
CNC
like really
stand
like
for?
fancy low tolerance or high tolerance. It's like when you make like really like fancy machined bits together and they like slip into each other and you like can't see like the grooves in between them. I thought that was CNC.
Mhm.
It also stands for consensual non-consent.
Wait,
So
what?
it's for like people who have like aggressive fantasies about like non-consensual encounters, but it is consensual, but you're like role playing that it's not consensual.
I see.
Anyway.
Mhm. I see. What's erotic roleplay? I don't know much beyond that. That's all I got.
You just use a bunch of asterisks. You go to town. You play Final Fantasy 14. You pick the Crystal Data
Final
Center.
Fantasy?
You go to Balmung and you go into the quicksands, and that's erotic roleplay.
Wait, is
Do
it
not.
Final Fantasy?
Well, I mean, it's usually people say ERP in the context of like MMOs. So, I mean, I feel like the two big MMORPGs that are still around nowadays are World of Warcraft and Final Fantasy 14. So that's where I learned what ERP was. Actually, no, long time ago, I learned what it was through Terra. That I don't even know if Terra is still around, but I played that for a while, and then that's where I learned it was from. But apparently, it's also, you know, ERP CBT.
Yeah. Exposure and response prevention for cognitive behavioral therapy.
ERP CBT.
Yes. Yeah, the
Terra servers are completely dead. Terra is still around. Well, which one is it?
okay. My chat and your chat have some very different information here. Yeah.
They're both mods too. So who's really right?
I know. This is a mod fight. Who's the better mod? Oh, that's terrible. I shouldn't say that.
All right,
Yeah, now
have we prefaced this with enough psychiatry?
I think so. Let me 1 second. Look, I need to move us the fuck around. Let me just. I'm gonna. Oh, I accidentally made you large instead of small. I'm gonna make you very small in the corner here, and make myself also small in the corner here. Yay! Success. And then great, beautiful. We all see the thing. Yes, we all see the thing. Terra is going to be shut down in January 2027. That's like a whole year away.
That's a solid like 15 years. When did Terra come out? Like 2011, 2012, something like that. That's pretty good.
Yeah, that's not bad at all. Start quiz. Okay.
Oh boy. All right, here we go. Oh my god, I'm not ready for this. Okay.
Mr. Black is a terrible example name. What the fuck?
Mr. Black.
Okay.
Mr. Black is a 75-year-old man who is a resident of a retirement community. Oh, so you know he's getting some. Do you guys also have the thing with like the epidemic in nursing homes where like everybody's coming in with syphilis in their 80s?
Yes. Do I also have the thing? Yes. Unfortunately. Oh my god. Nothing's freakier than a nursing home.
Oh god. They're crazy over there. Over the past few years, the staff at the facility have become more concerned for his health. He is withdrawn, speaks softly, and is overly cautious when he moves. Alright, he's not getting so. His once lively expressions have dissipated. Now he rarely shows any emotional expression. That would be called flat face. At times, he appears frozen, not smiling, blinking, even for several seconds when someone calls his name. He was recently placed on fall precautions after many stumbles in the hallway. One nurse had noticed some unexpected involuntary movements at rest. Dietitian notices weight loss after he stops eating the majority of his meals. Social workers said when he went to sign some forms, his handwriting had become quite small and somewhat illegible. Social worker is also growing concerned that he may not be able to make financial decisions appropriately. What is his most likely diagnosis? Okay, so gut instinct. I mean, I'm worried about Parkinson's. Because of like insidious onset, flat facies. I'm worried about tremulous activity, involuntary motions, and like scribbling, illegible handwriting, and then that frontotemporal dementia, or he's not able to make financial decisions appropriately. Yeah, so I would be in between like Parkinson's and Alzheimer's here. What's the psychiatrist's opinion?
I think similarly, right? Like this is the thing I always have to remember with tests is like don't assume stuff that isn't in the STEM. So it's like it's probably not actually something more psychiatric because like does anyone develop a new psychiatric disease at 75 years old? Probably not. And then yeah, like insidious means that it like has like a slower onset over like a more chronic time period. Just if it doesn't mean dangerous, which is what I thought as a med student when people said insidious. And yeah, like he has like micrographia, which is like writing very small.
Oh, that's a psych word. Micrographia. Actually, that might be a neurology word.
Micrographia. Yeah, it's like thing and like
it's like what's the thing when it's like you can't feel a thing? Stereographia? Is that dude? There's so many like random.
When you can't feel a thing.
Oh no, it's like you can't tell what an object is when you grab it in your hand.
Yeah.
I think that's stereographia. No, that's not a word. No, it is. Wait, is it not? Word for unable to recognize object in hand. Tactile agnosia?
Oh, that makes sense, yeah.
Astriagnosis? It is always Greek, dude.
Yeah.
Astriagnosis.
Yeah, that makes sense, because agnosia is like unable to recognize faces is what prosopagnosia?
Prosopagnosia.
Yeah.
I know that because of a visual novel.
Okay, yeah, so I think we all agree Parkinson's. It would be really embarrassing if this isn't the right answer. Oh, okay, don't display this message again. Yay!
I have a 100% win rate.
Perfect. So like the thing they didn't say that would have been like blinding lights is like if they called his gait like shuffling.
Magnetic gait.
Yes, a shuffle.
Patient exhibits a 3 hertz pill rolling tremor.
Yes, exactly. Okay, cool. We probably don't need to show the explanation, although I guess.
Dude, 96% of people.
Oh,
okay. I was like, wow, I'm so smart, guys. I can take the psychiatry board.
Maybe, you never know.
I'm pretty sure like a requirement to sit for the boards is doing the residency program.
Well,
I don't think you can just take the boards and get certified in it.
You might be able to backdoor it though, because it's
like in the 80s, if you could like get grandfathered into shit.
That's true.
Oh god, this is a medical question.
That's what I'm saying. A lot of our questions are medical.
All right. A patient who is treated with lithium develops acute toxicity. Which of the following is true? Lithium is contraindicated in patients with all cardiac diseases. Lithium has a high therapeutic index. Overlap may exist between the GI symptoms of lithium toxicity and standard GI adverse effects. Lithium has a characteristic discontinuation syndrome. Thyroid and renal function changes occur early in lithium therapy. Okay. Okay, lithium, I'm worried about renal toxicity, right? Lithium has a low therapeutic index, which is why I don't fuck with lithium. I've never prescribed lithium in my life before.
Unfortunately, it's extremely effective for bipolar disorder, and like there's some things that nothing works except for lithium, which it's unfortunate because I also hate lithium toxicity stuff.
Ebstein's anomaly, that's the buzzword.
Yes.
Ebstein's.
With a B, guys, not a P. A B, I'm pretty sure. Ebstein's anomaly.
Dude, it's fucked up what Epstein did on that island, huh? What does that even have to do? Atria? Is it biatrial enlargement?
It's atrialization.
Atrialization. It has to do something with the atria.
Yeah.
All right. Well, I just said like the 4 or 5 things that I know about lithium, and I don't think any of these really are in the answer choices. I think.
Well, you got this one.
B.
Yeah.
I know for a fact it's not B.
Mm-hmm.
I think E maybe, unless it's like early in lithium therapy is like the buzzword there. Like maybe the kidney injury only occurs late in lithium. Like I don't know. Like I don't fuck with lithium, so I don't know any of these like side effects.
Is that your guess? Is that your final answer?
I'm gonna say E. Yeah.
Okay.
What's the psychiatrist's opinion?
Well, wait. I want to check it first because I'm curious. Yeah, I'm pretty sure that you're right. That it's not early. I guess it could happen early. It's usually after you've been on
it's more like
for a
usually
while.
It's like if the psychiatrist wants to start lithium, it's contraindicated in CKD. But it's like I don't know if that means it happened early or late.
Yeah, it's usually, in my experience, and also I'm just gonna guess, probably in the literature, like late, like you've been on it for a while. Like you'll check the thyroid and the kidney function, among other things, before you start, and then you'll keep checking it every so often. But it's not like clozapine or something where you're going to be checking labs like every week or every other week for a little while. It's like on the order of
clozapine, you're worried about agranulocytosis.
Yes, except REMS doesn't exist anymore, so we don't have to do that. No, it's a whole thing. We can talk about it later. I was like, I don't know how I feel about it yet.
We get a clozapine question. Hika says, I'm curious, does IM or Psych have a core exam equivalent for board eligibility? Wait, what is a core exam?
What is a core exam?
I don't even know what that is.
Is that a non-American thing?
Is a core exam? We're both Americans.
We're American. This is the red, white, and blue United States of America. Apple pie.
Is a core exam like an in-service exam? Like you're not allowed to sit for boards unless you pass your in-service exam, which I guess we have something like that, but nobody really fails their in-service exam.
No.
Like the passing threshold for in-service exams is like 5%. Something like that's the ice. So like everybody passes it, and you guys have Prite or whatever.
Yeah.
And I know this because I was chief, so I had to make the fucking schedules, and like the psych residents were always like, we have Prite. We can't go that day.
Is that what you think a psych resident sounds like? Wow.
Yeah.
Wow.
Actually.
I can't believe that you think you're acting like the psych interns are the nerds when y'all are the ones that talk about hyponatremia for 3 hours.
All right,
if we're going to be talking about stereotypes.
Let's be real. The neurologists are the nerds.
That's true. Yeah. No. Yeah. Yes. Also ID. Also nephro.
True.
Anyways, so while we were talking, I guessed what I thought it would be. Great. It's almost like I maybe know things. It doesn't have a characteristic discontinuation syndrome, and then it's this. I've never checked cardiac anything for lithium really, so I just hoped that I wasn't doing something horribly wrong this whole time.
Probably just Ebstein's.
Yeah,
they just want to get you from Ebstein's.
Right, because so basically what we're talking about is that if you are pregnant and you take lithium, there is a risk. It's very, very, very low, but there is a risk that the fetus will develop a heart anomaly called Ebstein's anomaly. But that doesn't mean that if you have heart issues that you shouldn't take lithium, because that's a separate thing. American radiology residents have a big exam at PGY3 called the core exams, which is for board eligibility. But I don't think it's like an in-service exam. Oh, so it is American. It's just...
Yeah, but I think it's rads.
It's
like,
just
it's a rads thing. Yeah.
I guess, well, because radiology is like really academic from what I understand, because everyone I know in radiology is like constantly studying. And I'm like, I'm not like studying that much.
What the fuck is this question? Dude, this is like the fucking history of asylums in America question.
Yes. Thank you for joining me in witnessing the weirdness of us. Is the IM board exam like this? Because like this is a large proportion of our questions. A large proportion of our questions are like this.
maybe we have questions like, what is the second most like common cancer in like males
but that
in
makes sense.
America or something? But like that's like a normal question. But like you're never gonna see like what ethnic group? I don't fucking know. Like, I don't know.
This feels like a trap.
Dude, like, because you know, like, people are gonna say indigenous people males, and then the answer is gonna be white males. But then it's just like, how like, ingrained in racism / historical outdatism is the American Board of Psychiatry
and
like,
Neurology.
And neurology, like, are they really going to let you say like indigenous people males smoke more than white males? Like, there's no fucking way.
I don't think
so. Dude, put down D.
I feel like we have to go there first.
No fucking way. No fucking way. Wait, put down B. That is fucked up. That is, why the fuck is this on your boards, dude? Why the fuck is this on your board?
This is a good question. That's a good question. You want me to tell you? So one of my favorite like, we get history questions on our in-service exams.
Yeah, I know, and this isn't even history, dude. Like,
oh, I know, but we get questions like this and also history questions. Like, it's okay. Anyways,
Sagittarius says, "Please show the explanation." No, bro, 17% of people are with us. 17% of people are with us.
17% of people are woke.
30-year-old indigenous people, males and females, have the highest smoking rate among U.S. adults. The report, Cigarette Smoking Among Adults, U.S. 2004.
2004?
What the fuck? Reveals that with the exception of American Indians, Alaska Natives, women in each ethnic group are less likely to smoke than their male counterparts. Smoking is also becoming increasingly concentrated among people at lower income and educational levels.
This doesn't explain the answer.
This doesn't explain anything. Also, you can tell it's 2004 because vaping is not part of the conversation at all.
Yeah. References. This is in the APA like textbook of psychiatry. That's hilarious.
Bro, that's so ass.
All right, well.
Why would you need to know this? Why would you need to know this?
APA, don't ignore what this person's saying. I love you and would love to be board certified. Please ignore the stream.
Fuck the APA.
I would love to be board certified someday. It's been my dream since I was a child.
Aren't some med students now younger than that source? If you graduate high school at 18, college at 22, and you start med school at 22, and you were born in 2004, yeah, you would be 22 right now. That's crazy. Oh, whoa. Okay, this is actually like a medical question. Okay,
yes.
Which of this statement is correct regarding tricyclic antidepressants? Most secondary. Oh my god. Oh. I don't know if Elavil. Oh, you're looking. Okay. Most secondary amines have a higher affinity for blocking serotonin reuptake than norepinephrine. Dude, you can tell me that's like correct or incorrect, and I would believe you no matter what. TCAs have a negligible effect on QT interval. Okay, well, I know that one's wrong already. Overdose with TCAs can be lethal due to cardiac arrhythmias. Well, I feel like B and C contradict each other, so... And I know B is wrong, so...
Oh my god.
TCAs have a more robust response than stimulants for ADHD treatment, and E, more recently, TCA use. Yeah, so...
This is so like, random.
What the fuck? one, I really never see people on TCAs that much either.
Mm-hmm.
And like more often than not, if somebody has a TCA on their med rec, I'm usually discontinuing it because of QT prolongation on an EKG obtained in the ER, and then it's just like, yeah. So anyway, I'm gonna say C.
Yeah, I would agree. TCAs are a kind of antidepressant. This I don't know what to do with this. This doesn't make sense. Also, I don't know. In any case, yes, QT interval. It's like it's a heart thing. It's your heart arrhythmia. Your heart rhythm go bad if you too much TCA. So that's why C is true. This is like so not true that it's hilarious. Like stimulants for ADHD are the most effective treatment that we have in psychiatry, basically. Like the most. So yeah. And then this is also extremely untrue. Once we invented SSRIs, we never used TCAs again. The fun thing about TCAs is that you can't eat like stuff that have a lot of tyramine in them, like fava beans and cured meats and red wine, which is why there's cheeses. And cured cheeses. Something Hannibal Lecter in Silence of the Lambs. I don't know. They love saying that in medical school. I've never watched that movie, so I don't actually know what they're referencing. But
neither have I, but I've also heard that movie referenced in the explanation.
Right. Okay. Perfect. Beautiful. Yes.
85%.
Ooh. Yeah, they have a high overdose risk. You would treat it with bicarb.
Makinami Matsumoto says, question to the psychiatrist, why did escitalopram destroy my motivation and dull a lot of my emotion? I feel like my understanding of SSRIs is if somebody doesn't respond to one, you try another. And if somebody doesn't respond to another one, you try another one. And then at that point, I refer to psychiatry.
Yeah.
What is your treatment regimen with SSRIs?
It is basically pretty similar. 75 milligrams of escitalopram doesn't sound right because the maximum dose is 20 usually. So if it was escitalopram and you were on 75, someone's gone a little bit rogue, and I don't know what the reasoning is. There could be like a reason for that because I have seen people on really high doses, but
maybe they're mixing that up with the venlafaxine dose. Is that 75 is a
venlafaxine is 75 is a starting dose for venlafaxine, yeah. So maybe that's what it is. But either way, yeah, usually it's like for if you have someone with like kind of uncomplicated like depression or anxiety, you start with an SSRI. If that doesn't work, try a different SSRI, choose based off of side effects. If that doesn't work, try a different class of antidepressant. And then if that still doesn't work, at that point they have like treatment-resistant depression, and you can kind of like choose how you want to go from there depending.
Esketamine!
If you want to make a lot of money, that's what you can do, yeah. But yeah, no, SSRIs can do that because like the way I think about it is one of the things that antidepressants can do is they kind of constrict the range of your emotion. This is a very simplified way of putting it. So like for someone who has like depression or anxiety, part that an SSRI can help with, the way that we think about it is that maybe they're like too reactive, like they get too low or too anxious. And so if you sort of like constrict that a little bit, it's helpful if you have depression and anxiety. For some people, it can be too much, and then you feel really, really numb, like it doesn't help you feel better, you just feel nothing. And in that case, maybe SSRIs are not for you. You can try something else. SNRIs maybe can help because they have some norepinephrine, which is adrenaline, so it helps perk you up a little bit. A lot of this is theoretical though, in terms of like differences between one med and another.
That is like my biggest, not gripe, but just like confusion with just like the gray area of like right? Because SSRIs are so common, right? And in residency, when I was working as a PCP, right, like I would offer to patients like, yeah, I can start you on Prozac, I can start you on Celexa, like I can give you, like, it's within my scope of practice to start these medicines as a primary care physician. But like when it comes to titrating, when it comes to you know, assessing the psychiatric cause, like getting you, you know, plugged in with the resources to like undergo like psychotherapy and stuff. Like I don't know why I'm allowed to do these things, you know? Like imagine if this was like a gynecologic question, right? And like somebody was like trying to get me to diagnose like ovarian cancer in them. Like of course I would immediately send that to OB-GYN, right? But it's like I feel like in the primary care system, we have so much freedom with or overlap really with psychiatry, and I don't know if I feel comfortable doing it sometimes, right? Like I would be okay starting somebody on, you know, Paxil, Prozac, whatever, but I feel like titrating or switching after that, like I really don't know what I'm doing at that point. Like what do you think like a primary care's role in psychiatry should be?
Oh, so I feel like I completely agree, right? Like, because I feel like a big part of a psychiatrist's expertise is like as a diagnostician, I guess, right? Because SSRIs are like an easy and pretty like safe and easy to start and relatively easy to titrate if you were just doing one in a pretty uncomplicated patient. For someone who has MDD, like depression and anxiety, but like actually diagnosing someone with that in practice is often super, super messy. Like, you never have a super clean case of like, oh, this person has literally nothing going on and now they have a very clear episode of depression. It's always like, well, their life is falling apart a little bit and they also just got hospitalized and maybe their mom has cancer, and so is this depression or is this whatever, or who knows? Are they tired because they have some other thing going on? Like, we don't have objective tests, right? So like diagnosis is really hard, and I think that's where psychiatrists like what we specialize in. So in an ideal world, I would love for PCPs to be able to send everyone to a psychiatrist to get like a diagnosis, right? Because we don't have like an objective test. A PHQ-9 is not a test, it's just a screener. But we can't because there's not enough of us, and also insurance would never pay for that. And unfortunately, that's a consideration that we have to take into consideration. So like in the absence of that, I think starting an SSRI in like a pretty obvious case of depression or anxiety, I think is fair. But like beyond increase every 4 to 6 weeks up to max dose if tolerated and see if benefit. Beyond that, I don't expect any PCP to be able to do more than that, because it does get complicated once you're like trying to switch or trying to augment or whatever, you know?
Yeah. But then it's like the patient's like, no, I don't want to see a psychiatrist. I don't want to see a therapist, right? Like I just want to keep trying taking these medicines. I'm like, I don't know, man. Like I don't know how much it's going to keep helping you, right?
Yeah, no, exactly. And especially it's like once you're at that point, it's like, well, this isn't like your area of expertise, because like this is something we talk about a lot too in psychiatry. Is like diagnosis is such a big part of it. Like you'll have someone who's tried a million different things for like MDD, and then you're like, well, maybe the diagnosis is wrong and maybe it's actually something else, and that's why nothing has worked. And that does happen. Unfortunately.
Atomelic, fluoxetine. Oh, right. Yeah, we haven't done the question yet, but probably is fluoxetine because it's SSRIs for compulsions. Okay, fine. Last question about SSRIs. Makinami says, is fluoxetine pretty much Lexapro or a different drug? Okay, so when you actually are, you know, prescribing an SSRI or switching SSRIs, right? Like, you're doing it based off of side effect profile? Like, always?
For the most part, it's usually a combination of like side effect profile, interactions with other meds, what's the word? Pharmacokinetics. Like, for example, Prozac has a... Huh? What?
Pharmacokinetics.
What?
You sounded like a nerd there.
This is the only thing that I can be a nerd about, okay? Let me live. No, yeah, look, okay. Half-life. Literally.
Okay.
Like Prozac has a really long half-life. It's like 2 weeks.
Oh, really? I didn't know that.
Yeah, Prozac has a really long half-life. It's like 2 weeks. There's some that have really short half-lives, like Paxil or what's the other one? Venlafaxine also can have a. Is that
why we use fluoxetine in stroke rehab? Because the half-life is so long?
Probably. So So it's SSRIs generally are good in stroke rehab because SSRIs help with like learning and neuroplasticity, like the ability for your brain to keep
that
learning.
word. Okay, I have heard fluoxetine helps with activation and neuroplasticity.
Mhm.
I have no idea what the fuck that means. I just see it on the med rec. I'm like, yes, fluoxetine, great choice.
Oh,
Wonderful job,
my
doctor.
gosh. Do you want me to give you my like psychoeducation spiel for what that means?
Just give me, just like 1 minute rant. What does neuroplasticity mean?
Okay, neuroplasticity. Neuro as in brain, plastic as in like they mean like Play-Doh. Like you can
Easy to mold.
easy to mold. Yeah. So basically, okay, if you think about your thought patterns, like have you heard the term like neurons that fire together, wire together?
No, is that a thing people say? Is that a psychiatry thing?
No, medical school.
Neurons that fire together, wire together.
Guys, I'm being bullied. Guys, I'm being bullied by my Oshi. This is not fair. I was excited.
No, go. Okay,
I was
haven't
excited,
heard
and now I'm
I
not
haven't
excited
heard about
anymore.
that, but no, go on.
Okay, basically the idea is that the more you have a certain thought pattern, the easier it is to have that thought pattern, right? Like, okay, do you know about desire paths? I'm trying to make a metaphor.
Desire paths? Like desire sensor in Monster Hunter?
No. As in, like, in real life, okay, imagine that your brain is a field of grass, right? If you walk over in a certain
Dude,
path...
your metaphors are crazy right now. Okay. My brain is a field of grass. Go on.
Yes. If you a thought process is like walking through the grass, right? If you walk through the grass on the same line over and over and over and over and over again, it becomes like a path, right? Like the grass gets
Like you trample on the grass and
Yeah,
you create paths and
you
stuff.
create paths, and so then every other time it's like easier to go down that path, right? Kind of like water, a river making a canyon. That's probably a better metaphor. Like a river making
And
a
okay,
canyon.
when we're saying these, are we talking about like thought processes
Yes.
or like neuron signals like move your left arm? Like
Thought processes, which are ultimately neuron signals, but yeah.
okay, but like we're talking about like mental stuff, not like
Yeah.
physical motions.
Yeah, but because it kind of translates to physical motions, that's why it works for depression. So it's like, stop having the thought process of everything is my fault and the world is terrible and there is no hope in the world. Stop doing that and kind of like climb out of that like thought pattern and think something else, to make it easier to think a different way.
So SSRIs basically mow the lawn so that you don't have as big of a rut in that one negative thought process.
Yes, basically, yeah. It's like instead of like, oh, this thought process has made a Grand Canyon in my brain, like it's like, oh, it's just a little bit of a dip, then I can climb out of it easier. And it's the same for other thoughts or neuron impulses like move your arm, move your leg, which is why it helps in stroke recovery.
Oh, fuck. I just learned. Whoa, wow. Wait, actually, that's pretty cool.
Right?
Oh, okay. Damn, wow. How did it take me 4 years of medical school and 3 years of residency and one Twitch stream to actually understand the concept?
See, because nobody tried to explain using a metaphor.
Okay, then quick differences like Prozac, Lexapro, Celexa, Paxil, right? Like what are the side effects that you are like at the top of your brain like most concerned about like for a patient? Like what would give you an indication to switch from one to another?
Okay, so like the meaningful differences between SSRIs. Okay, so all of them are going to give you like weird GI side effects, you know, like because you have serotonin stuff in your gut too. So it's gonna make you like kind of queasy or have diarrhea or whatever. And they also all cause sexual side effects, as in time to completion is usually increased and also libido is usually decreased. So those things are all kind of the same. You wouldn't really have a difference changing from one to the other. The big difference would be like if like someone's like, oh, every time I miss a dose, if I accidentally miss a dose, like I start getting brain zaps because that's from discontinuing SSRIs or some other horrible symptom, I'll be like, okay, well, let's switch you to something that's like got a longer half-life like in the body, so that if you forget to take it, then you won't get brain zaps and feel horrible. Or if there's like some specific side effects, like some SSRIs are more likely to cause weight gain than others, some SSRIs are more likely to have like weird activation or sedation symptoms than others. And the biggest one is like if you have an SSRI that's like kind of working, you're like, this is maybe working, but it's like hasn't fully solved everything, but I'm getting the sense that maybe an SSRI could be effective. It's not like it's doing nothing, so maybe let's try something else.
So then when would you, I keep asking questions about SSRIs, when would you consider switching from an SSRI to an SNRI or like a TCA? Because I never prescribe, like, unless I was continuing those medicines, like I would never start Elavil on somebody. I would never start Effexor on somebody. Like I limited myself just starting SSRIs, and then after 2 or 3, like refer to psych.
Right? I think like, that makes sense.
Yeah, but like what is your thought process for like actually getting somebody on amitriptyline, you know?
Usually we would go like SSRI and then SNRI. If it's like it kind of works, but not a second SSRI also kind of worked but didn't really work, so maybe SNRI. Why? Plus to minus. Sometimes it's like based off of like FDA approval stuff, because that just shows research, although we do think that these things are pretty interchangeable, but there's some SNRIs that have more research and like it works well for OCD specifically or for PTSD specifically. So that's why you see a lot of people PTSD on Effexor. What was the other thing? Oh, TCAs we almost never use, except for OCD. There's one that's really good for OCD, and it also helps with pain. So
for fibromyalgia, right?
So if there's like a crossover there, then sometimes people end up on TCAs. They're also sedating, so they can help people sleep if they also need that, plus antidepressant stuff. Yeah, that's pretty much it. It's like the thing with psych is that in practice and clinically, it's kind of like, what are you familiar with? What did you use a lot in training? Yeah.
That is interesting. Yeah, because it's like it's not as flow charted like in medicine. I mean, like it is not like internal medicine or something, right? Like for heart, like hypertension, something like there are like JNCA guidelines, like we follow very specifically like down the path. And then we also have to like worry about insurance and shit.
Yeah.
But you know, like we have like if A doesn't work, we go to B. If B doesn't work, we go to C. Like we have all of these like things that are just very much set in stone. But psych, it seems it's like half the time it's like vibes, right? Like you're just worried about like how your patient's gonna respond to this new medication, because you might not actually know like what side effects that they're going to exhibit or not.
Yeah, because unfortunately we just like don't have the evidence base that you have in medicine, right? Because like I remember on medicine,
that's so crazy to me.
Yeah, no, it is pretty crazy. Because your guys' like seminal papers and studies are like, we did this study that showed that you need this specific dose of a thing, and this is like goal-directed medical therapy, which is a crazy acronym to me, by the way, because it has no relevance to the thing that it's actually like goal-directed for what. Like, I said that acronym in front of a psychiatry attending once, and he was like, what the fuck are you talking about? And then I explained the acronym. It's goal-directed medical therapy. And he's like, okay, isn't all therapy
goal-directed?
He's like, I'm also doing GDMT. But you guys, it's like very specific, whereas our like big papers are like, we've discovered that if you have some improvement after 2 weeks of treatment, you'll probably have more improvement after 6. And like that's like a big thing.
Crazy.
Or this antipsychotic and this other antipsychotic are like roughly the same. That was also a big paper.
Roughly the same, not like not inferior or anything. It's roughly the same.
So yeah, it's a lot of vibe doctoring.
That's your Plato trial, roughly
Yeah.
the same.
I mean, bro, the fact that we have a DSM, like our standard is the DSM-5, which is great that we have something so that we're all on the same page while talking about the same thing, but it's a bunch of psychiatrists get in a room and decide what the diagnostic criteria are.
It's interesting. It's like, I guess for us, it's like we have landmark trials, right?
Mhm.
So what I said Plato earlier, right? Like
It's always a fun acronym.
Yeah, like Plato, Stopdapt, Courage, Syntax, Hope, Pioneer, AF, Dash, All Hat. You know, these things, like, I know these studies are like multi-center randomized studies, and that is like our version of the DSM-5, because like these are studies that are proven to have these effects over large populations, and that's why we. But it's like the DSM-5 is literally just like what a few people came together and decided was good enough for the practice of psychiatric, like clinical psychiatry. It's just like a whole different way of thinking, you know?
Yeah.
It's just because like people are not like statistics, right? Like, and the variables aren't always the same variables each time, and it's just so, it's kind of like you're wading through things a lot, and like there's a whole, you know, other side of like the mental health too. Like you're like not even expecting to address with the medications also. Like that's
That's why I like, I was a humanities person in college, so it's very close to that in my opinion. It's very like, it's adjacent to like philosophy and ethics and stuff like that. So I think it's fun.
Me too.
But yeah, no, like the DSM's crazy. Bro, if you find a DSM-1, by the way, for everyone here, if you ever find like an original, like early DSM, like 1 or 2, if it's like from when they were actually made, those are worth like hundreds of thousands of dollars. It's a big deal. Sell it to me. But the DSM-1 is so fun to read because it'll say shit like inadequate personality disorder.
I mean, this was probably like back in the shit when they thought that like orgasms were a treatment for like female hysteria or whatever, probably, right?
Yeah. Yeah, it's like Freud. Yeah, like before Freud.
Oh my god.
It's great. It's hilarious. I love that we've just been sitting on this question.
How did the AMA get to where it's in terms of research base? A lot of messed up stuff had to happen too. Yeah, probably. I mean, what like a lot of the stuff that we know about anatomy is like due to like war crimes from like World War II, right? Or like terrible experiments by like the Nazi and like Imperial Japanese armies like performed on prisoners.
Yeah.
And then like 10-15 years later, like people were publishing papers. They're like, oh yeah, we found that in pregnant women if blah 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 blah. Like, how did you guys figure that out?
Yeah. Yeah. Like tertiary neurosyphilis, or how long does it take for someone to freeze to death, or how much water is there in the human body? Horrifying things happened.
Neurosyphilis is Tuskegee, right? Yeah, like that shit was in our country, dude. That was 1960, something like that. I don't know.
Not long enough ago. Yeah.
Yeah. No, it was only 60 years ago. That's fucked up.
Yeah.
And then they only apologized for it like after I was born. Like.
So also a really long time ago.
Oh, fuck you. Tuskegee, 1997. Clinton apologized in 1997 for that. Like that is crazy.
I know.
Like what the fuck? Ugh. All right, let's go back to the question. All right, our goal is to get at least 10 of these done.
Yes. It's a very effective study session.
An adult patient presents for their first visit for anxiety. They describe feeling tense and anxious, stating that they only feel relief when shopping. The patient later reveals that they sometimes pocket small items during their shopping trips. They're ashamed of this behavior and then state that they don't even need the items that they have taken. During the theft, however, they feel elated. Which of the following medications can be used to treat this disorder? So it's ego dystonic. Right? That's a psychiatry word. You like that? You like that?
Yeah, good job.
Yeah, right? The patient recognizes that their compulsion is like detractive to their daily life, right? So in a question of OCD versus OCPD.
Ah, yes, that is the classic thing.
Oh shit, which one is ego dystonic? OCPD is ego syntonic? Okay, there we go.
Yeah. Yeah.
All right.
Because it's like part of their personality.
Anyway, this would be SSRI for the compulsions.
So we're going Prozac?
Yes.
Yay! I think what they're actually going for, is kleptomania.
Oh, this actually is kleptomania.
Yeah.
Because, but they don't like, they feel relief when shopping, not when stealing. I don't know, whatever. It says during the theft they feel elated. But they also say they only feel relief from their anxiety when shopping. That's why I didn't think it was actually like kleptomania.
Yeah, it's like, it's more, it's like stealing, but also like just the obtaining of things, you know? But yeah.
So even if you're like buying things, that's still kleptomania?
I think you do need to be stealing things, but it's like, I think part of the larger, what's it called? Presentation, phenomenology is like this weird like compulsive need to accumulate things.
Oh.
They don't actually really like stealing things. That's like the interesting thing about kleptomania. It's basically a variant of OCD.
That's what I was taught. Like kleptomania is like a specific like subtype of OCD. That's why I didn't like call it kleptomania.
Yeah.
That's why I was splitting into like egosyntonic, egodystonic.
Yeah. No, that makes sense.
I got honors in psych. It was my one honors.
Wait, really?
In my M3. Yeah, dude. I had honors in my sub-I and radiology, but that was my 4th year, so it didn't matter. But I had honors in psych. I had high pass in neuro and family medicine, and then I passed everything else.
Well, wait, what was I'm actually curious then. What was the like distribution of like high passes and honors and passes? Because they show like, that in your MSP, right?
They show that in your, yeah, they do. Psych, like, I'm pretty sure like half the people got honors or something. I know like surgery, only like 10 people in my cohort got honors, so like it's a lot lower. But I had pretty mediocre grades in med school. Like I graduated in like the bottom tertile of my class, so like I did not stand out in any way.
I mean,
yeah,
does that really mean
P
anything?
equals MD, who cares? I matched.
I mean, well, it's also like, what are they using to determine that? Oh, people liked you.
Did people like you? Did you recognize your attending's song choice in the OR, which made them build a rapport with you?
It's crazy shit. Like I was on a rotation with a friend, and like one of us, like we literally did the exact same things the whole time, and then one of us got a good grade, and the other one did not, and was like, this person doesn't seem interested. I was like, we both didn't talk. Like, this seems like racism.
Oh no, like my neurology private practice rotation, like
private practice, that's crazy.
I was with another guy, and the other guy is Hispanic and I'm Asian, or like my dad is Korean, so I'm half Korean, and the attending is Korean. So of course, like I end up with like a glowing evaluation, and the other guy just gets like a very average one. I'm like, we were both not interested in neurology. Like it just sucks like how the system is like that sometimes.
I know, it's fucked up, and a lot of times it's not even necessarily conscious. It's more fucked up when it is conscious, but yeah.
Oh yeah, that too. I got a terrible evaluation on my OB-GYN rotation, and in it, like, I think the senior resident evaluating me, like, specifically mentioned an incident where I, like, back-talked a nurse or something, which I never did. And in the bottom of it, he was like, I suspect that, like, some of these, like, the way that people perceive you might be due to your accent, not, like, necessarily your personality. And then I was like, you know, there's another Chinese guy in my cohort who's ESL on this rotation. And then I was like, I think he has me mixed up with Li Haoxiang or whatever. So I messaged the rotation coordinator, and then like 2 weeks later I got it struck from the comments on my rotation. I was like, there is no fucking way that this white guy actually mixed me up with the only other Asian guy on this rotation.
That's happened to me multiple times. I've gotten there was like, I'm okay. Chat doesn't believe me, but I promise I'm like pretty tall for an Asian woman, like memorably, but there are at times more than one tall Asian women that exist in the world, and I always get confused for we always got confused for each other. It didn't help that our names are kind of similar. And so like I literally would get evals that were meant for her because like I was like, this never happened to me. I don't know who this person is. Like what has happened? Or the best part is when they use someone else's name on your eval. That's also happened to me a couple times. Yeah, where they're just like, Cecilia is a great. I'm like, who the fuck is Cecilia?
That's such a Chinese American name, dude.
It's all my friends growing up were Cecilia, Michelle, Michael, Andrew.
Dude, Grace, Esther, Jenny, Angela. Dude, Angela. Oh, Angela.
yeah. Angela Wong goes hard.
Angela Wong.
Bro, I knew like 3 of them.
I knew like 3 David Lees growing up.
Oh my god.
Alright, wait, okay, wait, let's finish 10 like normal questions and then give me like 5 hard questions after this.
Oh, okay, I'll open a new practice exam.
Oh, this is fucking ass. This is not a good question at all. Oh my god, I don't want to do this. Oh, I'm getting a raid from Yomi. Wow, Yomi-chan is raiding with 8 patients. Hi, Yomi. Yeah, I'm doing psychiatry board review. Not because I'm trying to job change into a psychiatrist.
You should though.
I just want to see how fucked up this is. All right.
Look,
this question is fucked up already.
Yeah.
I'm looking at the answer choices. Like, this is so fucking stupid. When will I ever need to diagnostically know the prevalence? Like, is 60% versus 75%? Like, that's such a bad question.
Thank you. Like, do you feel like I need to know this?
No, this is terrible. Okay, 21-year-old male presents with complaints of excessive sleepiness, sleep hallucinations, sleep paralysis, and episodic leg weakness that's triggered by strong emotions. They often have to sit down to avoid falling and have actually fallen several times. Periodic daytime muscular weaknesses occurs in what percentage of people with this patient's primary diagnosis? So this is like narcolepsy, right? Like, it's like the strong emotion narcolepsy. Like, fuck, I know the diagnosis. Do I know percentage of people with periodic daytime muscular weakness? No. All right, what is the psychiatrist's answer?
I have no idea. I have absolutely no idea. Also, thank you,
I don't think
Rawberry92 for the follow.
Muscle weakness is very common though, right? Because it's usually like with laughing and stuff.
Yeah, maybe. And also, this is the other thing. I'm just gonna say this. People have a lot of opinions about whether psychiatry and neurology are the same thing or not. But this is one of those cases, like, I'm pretty sure this is more a neuro question than a psych question, but we share a board entity. So that's why I get a lot of neuro questions, even though I haven't done neurology in 4 years. Anyways, I have no idea. 25? That seems like a safe. Maybe 60? Who knows?
Who knows? What's the answer?
I don't know. No. Is it 60? Yes. Oh, okay, great. Cataplexy. Huh? Great.
Well, moving on.
well, look. I feel vindicated. Most people agreed with us.
If this is like the hard questions, like, this is so dumb.
Cause like, is it hard or is it just stupid?
Oh my god. Patients with which personality disorder struggle to achieve meaningful improvement with psychotherapy? Antisocial, borderline, narcissistic, histrionic, schizotypal. So, okay, well, borderline needs dialectical behavioral therapy, so I'm gonna say B.
B?
Fuck. Dude, I was so ready for that. I was just like, dude, I know this one uses like a different type of therapy. Like, fuck.
Other way around. It has a therapy that already makes it better than more treatable than other.
Oh,
classically.
Is dialectical behavioral therapy a type of psychotherapy?
It is, yeah.
Oh, okay. Fuck.
The key is the therapies in the name.
What?
if it has therapy in the name and it's a psych thing, it's a psychotherapy. It's like
Oh,
classified as
oh,
psychotherapy.
I actually don't know like what CBT and DBT and like all these things like entail actually.
Oh wait, really?
Like what is dialectical behavioral therapy? Like how is that different from like psychotherapy? I don't know.
Oh, wait, what do you think it is?
I don't know.
Ask,
Like,
tell, ask.
I feel like such a psychiatrist, dude. Okay, I feel like I saw a psychiatrist in med school, right? They
Good.
diagnosed me with ADHD,
Good.
but I did a little bit of, you know, I had to sit on the couch, right? Talk about my childhood. You know, I'm not sure if, like, is that what therapy is? Like, she was taking notes, right? Like, is that...
Okay.
psychotherapy? I don't know.
It could be. Well, so here's the general answer is that, like, technically you could probably add like supportive therapy to like anything, right? Like the rapport building supportive therapy, whatever, is like kind of in all patient interactions, which is why a lot of psychiatrists, or at least I am involved in like early medical education for like early medical students in terms of like teaching interviewing skills and stuff, because it's like part of it, right? But therapy is like, it's like a treatment. The idea is through talking with a provider over once, it's usually like an hour once a week. If you're doing something for an hour once a week with a psych person, that's usually psychotherapy of some kind, and it's to like try to change your brain patterns, change your thought patterns, change your behaviors. That's all psychotherapy. The differences are like in how they try to do that. So there's like psychoanalytic, which is like, I'm gonna try to go into your subconscious and try to draw that out to say like, oh, your subconscious and unconscious are the source of some of your issues. And then there's
But that's
like
real.
It is real, I think.
Yeah,
personally.
but that's not... Is that psychotherapy?
It's a form of psychotherapy, yeah. And then psychodynamic is another form of psychotherapy, which is like, oh, we'll try to give you restorative or corrective emotional experiences, and like, you know, the relationship between you and the therapist is going to take on aspects of your relationships and other parts of your life, so we can see how that goes wrong for you. That's another thing. And then CBT, cognitive behavioral therapy, is like more like manualized, skills-based, learning-based. It's almost like you get like a tutor. That's how I feel when I do CBT. Like I feel like a teacher. Like there's CBT for ADHD, for example. I highly recommend it. I do it to myself.
Do you do that? Like, is that not like a psychologist's job?
Yeah, I mean, psychologists and therapists. Basically, it's like a therapy thing. Psychologists do it, they get trained in it probably more than we do, but psychiatrists are expected to get therapy training.
Oh, okay.
Yeah, so we get some CBT training. This is the other thing that makes psych weird. It's like what you get trained in can be really different. Like we have this whole thing of like some psych residencies are more therapy oriented versus more biologic oriented. So like if you go into like psych subreddits or whatever, like, oh, this is a very like biologic program, which means they're very like medicine diagnosis. And some programs are more therapy focused, and in the therapy focused programs, some are more like talky discover yourself therapy, and some are more like skills based therapy focused. So in any case, it kind of depends. But yes, not a lot of psychiatrists do it though, because like people want to make money, and you make more money prescribing medications, because those are shorter appointments, so you can see more people. Yeah. But yeah, CBT is like you get like a manual. You can buy it online. It's on Amazon. The one I like is Treatments That Work.
Buy a CBT manual online.
Yeah.
Free online CBT workbook.
Mm-hmm.
A course in CBT tech. Oh.
Yeah. I recommend the one for ADHD. I go through it for myself. It's how I got through residency. And that actually, the fact that it was so helpful for me is why I decided to be like, maybe I should try to get diagnosed, because maybe this is helpful for me, because maybe I have ADHD.
How effective do you think this is for somebody like doing it to themselves?
It depends. I
like
think
going through a workbook versus seeing a psychiatrist. Like, what do you think are the success rates on those interventions?
I think it's for something like an ADHD workbook, it's probably higher because it's more skills based. It's more like, this is how your brain tends to work. This is the kind of like productivity system that might work for you, right? Like, make it as simple as possible. Just do it. Like the sort of like skills, thought process, life training sort of thing that's like helpful. But like, it's not probably that easy to do like an anxiety CBT or like a depression CBT, because some of what's helpful with that is that like you go talk to your psychiatrist or therapist, and they're like, well, let me confront you with the parts that you're thinking about this like in a way that actually worsens your anxiety, or tell you basically what you did wrong, and give you like homework and stuff. And it's like that accountability part is helpful, you know? It's like why it's helpful, like you can learn piano on your own, but it helps to have a teacher who can tell you like, hey, that sounds terrible, do this instead.
Damn, I'm learning so much right now.
Wait, actually? That makes me happy.
Yeah, because we don't learn this shit, dude.
No, it's awesome.
We're learning about like more landmark trials. Timmy ACS. Have you calculated his ABCD2 score?
ABCD2 score? Oh my god.
It's like if you determine if a TIA requires admission for monitoring for.
Wait, that's an actual thing?
What? Yeah, of course. What? Wait, what do you mean?
I thought you were making up a fake score that sounded like a real score, because they all sound
no,
like ABCD2.
It's ABCD2 score because you have to differentiate it from the ABCDE score, which is dermatology for melanoma. Dude, one time my fucking attending asked me if I knew what an ABCDE score was, and I was like, yeah, for melanoma. And then she was like, what the fuck are you talking about? No, it's ABCD2 score for TIA is like age is greater than 60 or nah, BP is greater than 140/90 or nah, clinical features of TIA, speech disturbance without weakness is 1 point, unilateral weakness is 2 points, and then
is this how you teach your medical students?
Yeah, because like this is why like medicine is just like so straightforward to me, like the more than psych, right? Because it's like a certain thing is worth a certain point, and then as long as somebody reaches enough points on the thing, I can justify my medical decision. That, right? So if I can say that like, hey, this guy's ABCD2 score is less than 2, like he doesn't need to be admitted for stroke monitoring, right? Like from a medical perspective, I have the power as a hospitalist to deny that admission, right? And it's not me saying like, I don't think this guy is sick, right? Like, or I don't think this guy will stroke out, but like I can always justify my medical decision making, you know, legally or also, but I can always say I calculated his risk factors, and by his ABCD2 score, this patient did not require, you know, admission overnight in the hospital. Like I can't admit this patient. There's no justification for it, and like their insurance wouldn't pay for it either, right? So like I can justify my treatment decisions using the appropriate tool. And that's also what we were talking about with like you and like the vibe, SSRI vibe medicine, right? Like I don't know how I would ever justify anything like practicing psychiatry in my PCP role, just because it was just like I don't know, like maybe we can try this, maybe I can like put you in with psych, but I don't know enough about this to like switch from A to B or C to D or whatever.
Yeah. No, that's totally fair. And I mean, that's why a lot of psych notes end up being quite long. I remember once I was writing a note and an ortho guy I knew came up behind me and was like, are you okay? Like, this is too long. Like, do you need help? Like,
right.
Is this a call for help?
Psych notes are like always like 2 pages long, going back to like the patient's like elementary school days and whatever.
Yeah, it all matters. Developmental history. But also like your assessments, my assessments are really long because like I have to justify what I'm doing. It's a lot of like I don't know, like on the differential, the most likely is this because it's most consistent with blah, blah, blah. However, the age of onset is blah, not consistent. Therefore, it would not be unreasonable to trial blah, and see if there's a you know, that sort of a thing. It's a lot. You're just writing an argument. So sometimes they end up being a couple paragraphs. But, what counts as antisocial behavior in the context of psychology? Oh yes, the question.
Antisocial behavior. Okay, so antisocial personality disorder is like one of the 10, 11 like specific personality disorders, right? It's like it's like the one where you're violent, right? Like it develops out of like one of the childhood like oppositional defiant disorders or something.
Yeah, conduct disorder.
Yeah, that one.
Yeah. So like basically, so colloquially, we say antisocial to mean someone who's like really introverted, like not sociable, like they don't socialize. In terms of antisocial personality disorder, we mean like anti-society. Like that's what they mean by social, you know? So like someone who doesn't work socially in this context of society. So they're usually people who like for context, there's a lot of like bias that goes into this in terms of like who tends to be diagnosed with antisocial personality disorder. It's going to tend to be people of color, or specifically like men of color, especially if they have a lower socioeconomic status. It's like a thing. But basically the idea is that someone with antisocial personality disorder like doesn't care about other people. It's like what we would colloquially call like a psychopath or a sociopath. Like the kind of person's like, I will hurt other people to get what I want. I don't really care about other people's feelings. I don't really care about if I am causing someone pain, like that sort of a thing. And so in a psych textbook, and I have feelings about this, but that's why this question is like not that hard if you've done a lot of psych stuff. In a lot of psych textbooks, they'll be like, oh yeah, the treatment for antisocial personality disorder is jail.
Oh, shit. Is that what the DSM-1 would have said?
Pretty much, yeah.
Oh my god. Wow, that's so blunt.
Yes.
and then that opens up a whole can of worms with the entire fucking criminal reform system, but
yeah. I mean, we're one of the only, I'm gonna say one of the only specialties, because I don't actually know, that has like fellowships that's literally like forensic psych. Like there's a whole field of like you work in the criminal justice system. Yeah,
that's true. I mean, because otherwise, like, we get, in our hospital where I was at in residency and now, right, like you get patients from the prison, like always, and they have like a sheriff or whatever like in their room at all times, and they're usually like handcuffed at the or whatever. So,
jail units are interesting.
I mean, in reality, some of the people who get the best medical care in the United States paid for and making sure they get all the correct medicine usually is like the prisoners. Because God forbid they die before going to trial.
Yeah.
So, I mean, the prisoners usually like come to the hospital like no questions asked, and then they get like admitted like immediately because they deserve it.
Okay. 8. Oh god, it's child's. You should be great at this.
A child. A child.
What? Right. The only thing worse than a rapist?
A child.
No.
The parents of a 7-year-old adopted, of course, Jesus. The parents of a 7-year-old adopted girl are concerned about her behavior. When they take her to the park, she will go up to strangers and easily go off with them, okay? She will go to the opposite side of the park and will not come back to check in for an extended period of time. Of note, she was adopted at 3 years old after being removed from her home due to neglect. The child receives a diagnosis of disinhibited social engagement disorder, which the following is the next best step in the management of this patient. What the fuck? I don't I don't even know what disinhibited social engagement disorder is. Yeah, definitely A, right? Right? Because it's like you wanna encourage them to like be with the family more, right?
That's what I would think. Okay, cool.
Good, because I wouldn't want to put like a 7-year-old on SSRIs anyway. Jesus.
Yeah, no, 7-year-old on SSRIs. Also, I'm just gonna reveal myself here. I've never heard of this.
It's on your boards.
I've never heard of this.
There's shit on my boards that I've never heard of too.
Like, what the fuck is that? Okay, anyways, I'm not going into child psych, so yeah. Do not the SSRI, exactly.
Hey, 1% of people wanted to the SSRI.
2% said order genetic screening. I mean,
genetic screening for what?
No.
She's adopted.
No, this. Okay, so I don't know about disinhibited social engagement disorder, but this is very classically like an attachment thing. You know, attachment.
Yeah, because they were neglected as a child, and then they were adopted and removed from the home. Yeah, like it just seems like a developmental thing, not even like a psychiatric.
Avoidant attachment. Blah blah blah.
Yeah, avoidant attachment. Those are words I know. I don't know disinhibited social engagement.
Exactly. This is.
Oh God! Oh my God! Which of the following theorists developed the concept of stepwise development through his theories of 8-stage? What?
This is actually...
Like, why do you guys have history questions?
I know. Oh, we have a lot of questions like this, yes, actually.
Okay, so, I mean, I know it's Erickson, but, like, I don't fucking know what any of these things are.
This is hilarious, because it's like, why? But yeah, it's
like,
Erickson.
Why do you need to know this?
Oh no, this is actually not that hard of a question. The actual hard questions are like, here's
what
this
are
person. No, not even what are. It's here's this person, we won't tell you the age, that's going through this current life crisis where they're worried about blah blah blah, but then also this is happening in their family. This exemplifies which Erickson stage.
Oh.
And I'll be like,
and then you have to answer, be like, identity versus
whatever. Yeah, exactly.
It's like, and then like, yes, they're 17 years old, and
yes.
Oh my God.
Yeah.
Why do you have to know this, dude? This isn't like psych. That's crazy.
Yeah. This is the sort of thing that pisses me. This is what I say about like psych all the time when people talk about the boards and things like that. I'm like, clinical practice is so removed from things that you could test in a multiple choice fashion that the things that we get tested on are often not super related.
Yeah. What the fuck? I suddenly stopped caring about learning stuff. Oh, okay. Wait, this looks like a medical. Okay. All right, I'm into this. 62-year-old man with a BMI of 33 and type 2 diabetes cannot achieve an erection optimal for sexual intercourse. Despite education, the patient continues to eat fast food and has a sedentary lifestyle. Glycemic control is poor. Serum total cholesterol is 390, trigs are 300, HDL is 35, LDL is 380. Which mechanism related to dyslipidemia can contribute to ED?
How is this a psych question?
Wait, I actually don't even know what the answer is. Hyperlipidemia results in reduced testosterone levels. Lipids inhibit PDE5. Concentration of plasma binding proteins are altered by hyperlipidemia. Hyperlipidemia leads to endothelial damage and smooth muscle dysfunction. Hyperlipidemia damages the perineal nerves. Hyperlipidemia causes autonomic dysfunction, leading to ED. Okay, well, I know it's not B because inhibiting PDE5, that's what Viagra does, right? So I actually made a post about this, I think like 2 weeks ago or something, right? So the way erections work is that, the blood fills up the corpus cavernosum. And when your blood fills up the corpus cavernosum, that bulbous spongy muscle swells and presses up against the veins in the penis. And that basically makes it hard for the veins to drain out the blood. And that's why the penis stays erect, because the blood sits there inside the penis. And this happens by inhibiting phosphodiesterase 5, which normally breaks down CGMP and prolongs the signal so that the arterioles stay dilated and the veins stay squished. So inhibiting PDE5 would actually give you an erection, not give you erectile dysfunction. I think you also probably need to know, like, if he's still having nocturnal erections as well, right? Because, like, actually asking a patient if they have morning wood is very important to know, because then this is either actually a psychological problem, like they cannot, like, maintain an erection during sexual intercourse, or if it's, like, a physiological problem, like, it's not just during sexual intercourse, but they just physically cannot maintain an erection at all. So the complication that you're worried about for a patient with hyperlipidemia is peripheral artery disease, right? And when their vessels are damaged from all of, like, the arterial plaques that they're getting, you can't maintain an erection because obviously the highways for the blood to travel through don't work well. So when you're worried about PAD causing ED, then you're worried about their cholesterol control, and his cholesterol, like his total cholesterol is above 200, trigs are above 250, HDL is fine, but LDL, the bad cholesterol, is above 100. So obviously he's not having optimal lipid control. So the correct answer, I think, here is D. Hyperlipidemia leads to endothelial damage and smooth muscle which really is more of a vascular medicine question. This has nothing to do with psych. I just went on like a 5-minute rant about this shit, and somehow this is a hard question for you guys because like 12% of people said A, like half of the people ended up picking different answers.
Yeah, I mean, so this, I think maybe what people get confused about is like, isn't it like, what is it? Aromatase is like in fat cells, so it's like a conversion to estrogen thing, but that's not hyperlipidemia.
Yeah, not necessarily. Yeah, that's actually more of like a PCOS like kind of way of looking at it. But yeah, I mean, this has nothing to do with like the erectile dysfunction like mechanism of action. This is a psych question, not a Lev question. Yeah, I thought it was endocrine, but I guess it's vascular. I mean, you are worried about cardiovascular disease, atherosclerosis, arterial stenosis, blood vessel occlusion leading to it's nothing to do with the actual psychiatric or psychological, conditions of ED, but it's just that this guy's vessels are so unhealthy that he physically cannot pump the blood through the vessels to maintain an erection that's leading to the this patient would rather have a heart attack first than have ED, but that's how they wrote the question.
Oh my god, I'm so confused because nothing here in this entire explanation has to do with the brain.
Yeah, it's not even a neuro question either.
So I'm just really confused. This is from the Journal of Sexual Medicine.
That was a great question, man. My ego. This is so ego-syntonic right now. I'm on fire.
All right, do you want to do 5 hard ones?
Yeah, go back to the Q Pank and give some hard ones.
Okay. New custom, tutor, hard, only, and we'll do like 5. Okay.
All right. A 77-year-old patient presents for evaluation after a minor fall at home. They state they tripped over an uneven carpet and narrowly missed hitting their head on the table as they fell. Although they were not severely injured, the patient is anxious about falling again. On physical examination, there's mild weakness in both legs. The patient has difficulty standing from a seated position, walking across the room and returning to a chair and sit. Which of the following interventions can reduce the patient's risk of falls? So that's like a timed up and go test, right? And they have
they're 77.
Mild weakness in both legs, and they're 77. How do you reduce the risk of falls? I mean, I feel like
education
about fall prevention, right? Like it shouldn't be that complicated, unless the answer is like C. I'm gonna say it's gonna be like C or E, right? Because like I feel like fall prevention makes the most sense, but vision correction is the simplest.
No. What?
Is it
exercise?
B? Oh my god.
Okay.
Oh my god, somebody redeemed my solid snake redeem. Okay, I have to read the next question like solid snake. Oh my god, patient education has not been proven to improve the risk rate of falls. That is not true because we do it in the hospital all the fucking time.
This is not true because like they tripped over an uneven carpet. You know what patient education helps with? Get rid of the uneven carpets and random cords and things that you could trip over.
Home. Yeah, exactly.
Make the light better. Make sure there's nothing you can trip over. Make sure things that you can see. Make sure that you have things that you can hold on to. And so like that doesn't help.
And then like vision correction, right? Because like you don't know how bad their vision is. What if their vision was bad? That's like one of those things where it's like you don't even think it's like a medical issue, and then you like look at their eyes and they're like -10 in both eyes or something, and you're like, oh, that explains it.
Yeah, but a large meta-analysis found that vision correction did not reduce the overall risk of falls. So what then?
No. Yeah, take this 77-year-old grandma to the gym, dude. Yeah, exercise her.
Yeah.
She needs OT. I mean, if it was exercise, like, if it said like Tai Chi, I 100% would have agreed, because like Tai Chi actually is one of those things where it's like shown to improve like balance in older patients. right? So that one there is like actually like a scientific thing right there. Oh my god, what the fuck is this? Through which enzyme system is Ritalin metabolized?
Is that Solid Snake?
Oh shit. Colonel, through which enzyme system is methylphenidate Ritalin metabolized? CYP2D6, CYP2C19, CYP2C9, CYP450, CES1A1. I think... Actually, I think it is E. Yeah, I think it is E because like the other one, the CYP systems are all like together, right? And I know for a fact that Ritalin is not CYP inhibited because
Thank you,
there's
Astro
no
Moon, for the follow.
like grapefruit juice. One
Sorry, I'm muted
right?
on Discord.
So, DARPA chief. It's not E. Oh shit. CYP2D6.
I'm pretty sure.
I'm gonna say A.
I think it's A too. Oh no, it's not.
Oh, it's not CYP450. I know for sure it's not CYP450 because that's CYP450 is sick faces, calm, and crap GPS induce me to madness or whatever.
This one, I think. No.
I don't even know what 2C9. Dude, it's definitely E. It's definitely E because it has
E?
nothing to do with the CYP system. Fuck you, Spectral. This is why I'm the attending, okay? This is Oh my god, this was a hard question. Even though I didn't have like any actual like knowledge to answer it, I just did it based on the answer choices.
Wait, what?
Damn, 47%. Why the hell would you need to know this?
It's also because there aren't that many. So the reason why 2D6, I think, is what I would have said is because a lot of meds are metabolized through 2D6. Psych meds specifically, and so that's like a big interaction that we need to know about. And like I'm pretty sure it is, or at least I'm pretty sure I get taught that it's metabolized.
Yeah,
like,
it says it was previously hypothesized that MPH was metabolized by 2D6.
Okay, so I need to be up to date on random studies. Great.
That sucks, dude.
Great. I'm gonna be honest, I don't remember ever hearing about a CES system of metabolism.
That's why I picked, because it was different. Oh god. Okay. An adolescent begins to experiment with drugs and alcohol despite her fear of these substances. What best describes this behavior? Denial, splitting, acting out, regression, counterphobia. I mean, I feel like by definition it's counterphobia, right? Because like she's afraid of it, but she's doing it, right? Okay, that was an English question, right?
I don't know why this is hard. Like,
I mean, it could be acting out though, right? Because it's like, why is she experimenting with drugs and alcohol? Let's examine that.
Oh. Well, in psych, I think I'm just gonna, it's a little different from like acting out in what we mean normally, you know, where we're like, oh, this person is like frustrated, so they're gonna, you know, it's like, it's specifically, expression of unconscious conflicts in a setting other than the one in which they initially arose. So, I don't know. Counterphobia is weird though. We don't usually talk about that. I would honestly call this more like, what's it called? Reaction formation.
Oh, reaction for that's a psych word. Oh.
But yeah. Denial is obvious. Splitting is when you're like, it's all good or all bad. Regression is like age regression. You get more immature. Cool. Well, we got one right.
Yeah. Oh god. A patient with opiate use disorder and alcohol use disorder is treated with naltrexone and acamprosate, which is correct regarding acamprosate. Acamprosate is extensively protein bound. Acamprosate levels increase when given naltrexone. Acamprosate levels increase following co-administration with food. Acamprosate has a high oral bioavailability. Acamprosate's pharmacokinetics are significantly affected by alcohol and
ANC 396, thank you for the follow.
Okay. I don't know if I like this.
Yeah, me neither.
Okay, so what is acamprosate? It's a GABA thing, right?
Mm-hmm.
And then naltrexone's a partial agonist.
Mm-hmm. Opioid.
All right.
Yeah.
Yeah. That's all I got for you.
Antagonist.
That's all I got.
Okay, so basically this is crazy because it's like, I don't know, I've never seen someone on both of these meds. That doesn't make any
Right?
any
Because
sense.
you can use naltrexone for both.
Yes, you can use naltrexone
Yeah,
for both.
you can use
should.
naltrexone for both. You should use
Actually.
naltrexone for both.
It
yeah,
works better.
yeah.
Yeah, no, don't. So naltrexone, naltrexone is just good for a lot of like substance use disorders. It works really well. You take it once a day. It's usually pretty well tolerated. It also comes in a form where you get an injection once a month, and it lasts for 30 days, so you don't even need to remember to take the med every day. It's really good. I really like it. Acamprosate, horrible. Never seen it work, so I shouldn't say that.
Damn.
Acamprosate is really hard to use because, for one reason, you have to take it 3 times a day. And taking anything 3 times a day is fucking annoying, and no one actually ends up doing it. The other reason is the dosage is 666 milligrams, and do not ask me why.
Not even 667?
No,
Because I know like
666.
like Foslo is dosed at 667. 67. 667.
Of course, that happened at some point during the stream.
I'm younger than you. I'm allowed to
You're
to say
not
that.
younger than me.
Oh.
You are definitely not younger than me.
Oh, okay.
Wait, I can guarantee you're not younger than me.
I was born in 95.
Yeah, you're older than me.
Oh shit. Okay. You're not. I don't know. The PGY 4. Wait, what year were you born? 97. Yeah, I mean it's like the same age. It's like 2 years. It's not a big deal.
I never said it was a big deal.
Okay, whatever.
But
Yeah,
I did say that.
97 and 95 are like the same thing.
Uh-huh.
The only difference is that I'm an attending because IM is a 3-year residency and psych is 4 years.
Exactly. I
Yeah,
am 3 years, psych
exactly.
is 4 years, so we should be around the same age. So I don't know why you thought that I was older than you.
Oh, I don't know.
Are you
just
saying
seem-
I give elderly vibes?
Yeah, you just seem more mature than I am.
No,
you're the same age as my girlfriend, and she's a lot more mature than I am. Maybe it's a me problem.
Maybe it's
maybe
women.
I'm just immature.
Men.
Maybe it's just a man problem. Oh my god.
Yeah, maybe that's what it is. Maybe it's just you. But yes, acamprosate, 666, 3 times a day is.
You think it's not given together because they interact with each other, so like B is the correct answer, right? Because it's like all of these other things could possibly be true, but acamprosate levels increase when given naltrexone, probably because it's like inhibited or something. So it's like that's why you don't see them prescribed together.
I don't know. Maybe, sure.
Dude, this
Oh,
is
yeah.
how I answer. This is how I
That's
answer
actually-
test questions, dude.
Yeah,
It's like
yeah.
you don't necessarily know the right answer, but the way that they give you the multiple choice questions is like, oh, these things can't all be true. So like, if they contradict each other, one of them has to be wrong.
This happens all the time. Like, seriously, I feel like probably 30% of my score on any given multiple choice test is just from like a 2-hour course I took once on test taking strategies. You know, it's like not even like I know the answer. I'm just like, I just kind of know how this should go. Like,
I haven't picked A in a while.
Exactly.
It's probably A.
well, no, you know, it's like, well, I know this isn't true, and I know that isn't true, and blah, blah, blah. Or like, oh, they actually answered this question in an earlier question, so let me go back.
Oh, smart. Actually, no, I do that too. Like when I was taking boards last year, like you get like a little like whiteboard sheet to write things on, and then I would just like write down like facts like on like the whiteboard sheet, like previous questions gave this away in the stem. It's like a true statement, so I'll like write it down on the thing to keep it for later, like if I get a question on it.
Oh yeah, no, I had a whole like list of things I memorized for step 3, the one with the role-playing part.
But the role-play, dude, step three was so fucking stupid. Such a waste of time.
It was.
And actually, like, it was probably like you actually have to like study for it. Like I always said like ER, IM, family medicine, like step 3 was just like a waste of time because it was just literally what we do every day. But for like people in surgery or psych or like anesthesia or like not in like a medicine intern year, so like path or something, right? Like you're 4 months, 3 months into residency, like learning completely different things, and then they're like, hey, like can you just take step 2 again real quick?
Yeah.
That's what it feels like.
Yeah.
And I feel bad.
It's like, can you pretend you're in the ED and you have to decide, should this person go home or should they
Yeah,
go
like
to
how
the hospital?
why the fuck would a psychiatrist know that?
It's a good question. It's how I feel every year that I'm glad that I know BLS. I think basic life, whatever the S
Wait,
stands for.
do you not need to know ACLS for psych?
No, we do need to know ACLS.
Okay,
I just
good.
think it's good, but also like if I need to use ACLS stuff, something really wrong is happening.
Okay, well you can still encounter like ACLS stuff in the field. Like it's a very rare time, but like, you know, you should still know how to like do these things.
Well, I feel like I should know how to do like an AED and like basic stuff, but like once I need to know epinephrine shit, I'm like, I don't, IVs, no. IVs.
Do you remember the ACLS algorithm at all?
Not really, but I am also due to retrain, so that's probably why.
Actually, I think I have to renew my BLS in May. That's actually, thank you for reminding.
Yeah. BLS, ACLS renewal season is coming up. But like the thing is, like honestly, like in what situation would I have access to an IV? Like they don't exist on psych units because it's
Oh,
a
actually,
ligature.
you're right. Actually,
Yeah.
because when I think about it, whenever they call a code, we have to go to those.
Yes.
Because you guys don't do it.
I literally, bro, I once had someone coding and like we don't have IV pulls. I think thank God the lactated ringers was like actually not expired because I don't think we've had to use it in like a decade. And like literally like holding an IV pull, we stole an ultrasound from a nearby unit and stole one of their IV kits. And I had to place an IV and I was like, thank God I still know how to do this because of medical school, but like, Jesus Christ, you know? Anyways, we just stick people with needles into their muscle. We can do that.
On the rare event of NEMS because of haloperidol and you don't have the antidote. Yeah, that's your job. You gotta go.
Yeah, I don't think I've really ever seen that. I've seen it suspected, but it's like really rare. That and serotonin syndrome are actually way rarer than you would expect based on how
I had
tested.
one case of serotonin syndrome in all of residence. That was nice. We had to put them on like, it was crazy. We had to put them on like Versed drip and like all of this shit. I was like, damn.
Did you guys actually use what's it called? Cryptopeptidine?
We did, but I don't think it even like helped or something. Like it was like yes, it's like the test answer, but like we had to use the midazolam to like sedate them appropriately.
Yeah.
It was scary. Like the hyperreflexia and everything, like it was all there.
Yeah.
And it was like almost like ballistic, spastic, and I was like, holy shit, like this is actually real.
Like hemiballismus? Sort of ballistic, you mean?
But no, like the degree of hyperreflexia.
Oh.
Like you would just like tap the wrist and would like shoot up like
Jesus.
It was crazy, yeah.
That is crazy.
I've seen it 2 times, one because of acetylcholine and the other because of haloperidol. Hey, have you ever seen somebody actually? Oh wait. Let me ask you this question, like as a psychiatrist. Okay. What is the antidote to valproic acid overdose?
I actually don't know.
It's an antibiotic, actually. I mean, like, it's not a common treatment, but this antibiotic can be pushed, you know, in cases of valproic acid overdose to reduce concentrations in the bloodstream.
Seriously?
Yeah.
Yeah, I don't know.
It's meropenem.
Whoa.
I don't know why, but apparently it's a
Meropenem?
thing. And I was
That's
just open
I don't know
question,
much
has
about
anyone
meropenem.
actually seen that pushed? Like,
Yeah.
it is crazy to me that works. I don't even know the mechanism of action.
That's crazy. All I know about meropenem is it's a big gun.
It's a carbapenem. You need like permission from like
Yeah.
ID to use it.
Yeah, because
It
it's a big
inhibits
deal.
acyl peptide hydrolase, an enzyme in the GI tract that metabolizes valproate glucuronide into free active valproic acid. By blocking this, it forces the elimination of the drug rather than allowing it to the blood. Yeah, Adam Ellick knew. Like it's like a weird thing. It's like a weird
So
intersection of like
crazy.
ID and psych or something. But
Yeah.
if you don't have like dialysis immediately available to you or something, then you can push meropenem like in the meantime. It's nutty.
It's crazy. Yeah. We don't actually know as much as you would expect probably about like overdoses other than some of the common ones, because like in practice, like if someone's having medical issues because of an overdose, like it's not us that's deciding what to do. Like there's bigger issues at play. You know, it's like, oh, we've called quick care and also poison control. And I was like, great, because I am not the person to call.
All right, it's like 10:30. Last one.
Yes.
Which of the following statements about treating chronic pain with pharmacological agents is correct? Oh boy.
Lithium.
NSAIDs and lithium have no major interactions and can be used together. Yeah, let me just run that by nephrology real quick.
Who the fuck is using
The
lithium
analgesic
for
effects of TCAs occur at higher doses than used for depression. TCA serum levels can help establish dosage of medication. TCA levels can only be reliably followed for desipramine and imipramine. Okay.
What?
I feel like C and D are, again, a pair that contradicts each other, right?
Yes.
So, okay, we know A is wrong. I don't know if B is wrong, but I know it is used for, you know, depression and chronic pain, right? Because we were talking about fibromyalgia earlier. But like C, have I ever drawn a TCA level before? I don't. What? Outside of a poison control context, what would I draw a TCA level for? I don't know.
I don't think there is much other context. So like the times that I've drawn a TCA level have been, I have a patient on a TCA that like interacts with some other medication that they're taking, like metabolism wise, and so in terms of making sure that they don't have too much of it in their blood. That's it.
Yeah, and like for levels and stuff like this, like I'm not doing it for TCAs. Like I'm doing it for like tacrolimus, you know, immunosuppression, or I'm drawing like a daily INR for people on warfarin. Like TCAs are not something that I generally care about on a daily dosing basis, because you would establish dosage of medication by drawing it like it's a trough, like Vank, right? Like it's not something that you need to monitor, right? So then it's like, is it D? Because it's like you don't even need to monitor it. It's not even worth monitoring. Can you not even monitor it reliably? I don't know.
Yeah,
That's my logic.
Yeah. Do you want this one?
I want that one. Damn. Okay, so then it is C. So people actually
C?
do use it?
Oh.
Oh my god, what?
I
Wait,
feel
show the
like
explanation.
this might be like a.
Wow, 41%.
Okay, so this is the same thing, but like I feel like they have a different definition of established dosage, because like I feel like when I, and also you probably, hear established dosage, I'm thinking like lithium, like you're getting a level to tell you should I take this up or down because I want to get to a specific like blood level, whereas this is more just like, let's make sure it's not too high.
Yeah, it's a weird question.
Thank you.
And also, the only TCA levels that can be reliably followed are for desipramine, imipramine, and nortriptyline. So
Okay.
like the D was basically correct.
I love how they're just
Like
this
it's
is
literally
true,
saying.
but there's a third
like,
one.
Yeah, like that's. What is nortriptyline? Pamelor? I've never. Pamelor?
That sounds
What the fuck
right.
is Pamelor? Who uses these medicines?
Almost
Oh,
no one.
Aventil? Okay, fine. In 2023, is the 204th most commonly prescribed medicine in the United. All right.
People
my
rank
bad.
these things? Okay, I don't
My
know
bad.
that. I don't know that.
I was not familiar with your game.
Sorry, I didn't know
Oh, that was rough. That was a rough one.
Well, I would have done about the same, so, you know.
Basically, we have determined that your performance on the psychiatry board exam has zero correlation with your actual knowledge of clinical practice of psychiatry.
You know, that is my suspicion as well, but I feel like I probably can't say that until I've actually passed.
Actually pass and become board certified. That's true. That's true.
It costs
You're
so
not
much
even
money.
you're not even board eligible yet, dude.
Well, yeah, I do need to apply to take the boards, but...
Hello? You haven't applied yet? Dude, for IM, you have to apply in like December.
Oh, no, our deadline's in April.
Oh, okay, good. No, yeah, that's crazy. Like we every year we always have to send out an email.
Oh,
Like,
yeah.
Hey guys,
Oh.
like the program does not like register you for the exam, and I know it's in July, but you're gonna have to register by December. So if you don't do it, you will fuck your entire career.
Yeah.
So you need to get on top of it.
Yeah. No, ours are in September.
Hmm.
It's weird because I feel like in psych it's maybe... Well, okay, I have a question. When you get like job offers or like solicitation, I guess, does it say like they want you to be board certified, like the like specifically?
No. It's always like, unless it's like a super senior position where you're like a senior hospitalist manager or whatever, like it's always board certified, board eligible, or
Okay.
BEBS,
Okay.
BEBC, board
Okay.
eligible, board certified. Yeah.
Yeah, that makes sense.
Because the reality is, like, most new job offers are picking out from like newly graduated, so it doesn't make any to like delay them. And like when I was doing my job offers, like there was no like compensation difference between if you were board eligible or board certified.
Yeah, no, same. Okay, makes sense. Yeah, I don't know. Like, I feel like some people don't even take, like, I've heard in psych, some people don't even take the boards until like a year out or 2 years out.
Really?
Yeah.
That's interesting.
Yeah.
Maybe just because IM is so broad, like once you start doing hospital medicine, you probably like lose a lot of it. But like
That makes sense.
psych, it's so irrelevant if you remember whose
Psych.
8 stages of social development were there or not. Like either you know it a year later or you don't.
Bro, one of the like the questions that I reliably get is like, who invented the asylum?
Yeah, that's literally the one question that I saw from like my cohort, like psych friends, is like Prite or whatever.
Yeah,
They
it's
had, like, the
Dorothea
history
Dix,
of
by
the
the way.
asylum.
But
Okay.
yep, she invented the concept of the asylum. Blah blah blah. Kirkbride asylums. Blah blah blah. St. Elizabeth's Hospital is one of the oldest psychiatric hospitals in America. Like, there's
Why do you need to know this for your board?
good fucking question.
Oh my god, it's so dumb.
Yeah. I got questions that were like, what year was Freud publishing blah blah blah, and I was like, why?
Oh, that is dumb as fuck. I think the biggest curveball that I had on my boards was like, which of the following tools was developed as like a liver failure stage for
Interesting.
transplant thing first?
Mm-hmm.
And it's like child's pew, meld, blah, blah.
Oh, the child's pew. I actually know what that is. Yeah.
Yeah. I actually know what that is. Yeah, for transplant, it's meld. Like child's pew came first, but child's pew is more for mortality and like severity, and then meld specifically is mortality and severity, but in context of will the patient benefit from being put on a transplant list, like
That
more
makes
urgent
sense.
or not.
Yeah.
Yeah.
I
So
only
it
know
is-
that
it is a little
because
bit different.
one subspecialty in psych is doing transplant psych, doing transplant evals. So you sit on those transplant tumor board situation, transplant board, whatever. So I hear
That's
this.
crazy, dude.
Yeah.
Just sitting there and seeing like who deserves a liver, who deserves a heart, or whatever.
Okay,
I would hate to be on one of those committees.
I just listen. I'm just there to learn because I'm not doing that for my job. It was a rotation. But transplant psych is a very interesting field, I think. But it's crazy. Yeah, I could not imagine doing that.
Meld's NA now replaced all the liver stuff. I don't even remember the Lilly and Maddry stuff. Well, Maddry is if they're gonna respond to steroids or not. It's Maddry's discriminant function, so it's not really a score. Oh, it is a score, but it's basically like a threshold if they're going to respond to steroids as part of their acute cirrhosis treatment, and then or acute liver failure treatment. And then Lilly score is if you continue the steroids or not, or if there's benefit to not continue steroids. Oh, I should know what Milan. Milan is cirrhosis and hepatocellular carcinoma to achieve optimal long-term survival with liver transplant. Okay, this is an oncology thing. Yeah, this is actually like, how many tumors do you have? Are the tumors like bigger than 3 centimeters? This
God.
is.
Oh.
Why do you know this? Why would you ever need to know this? This is actually like what they do in tumor boards and probably determine who needs it or not.
I did a peds onc rotation.
That's depressing.
Yeah. It was my sub-I actually.
Why was your sub-I in peds onc if you matched psych?
Because we had to do a sub-I that was medicine, peds, or surgery.
What?
Yeah.
So you picked peds onc?
I picked peds. And then they chose peds onc for me.
That's great. No, dude, sub-Is are supposed to be on like the regular like floor, like peds floor, meds floor, surgical floor.
Oh,
that's
it was
crazy.
No, it was a floor team. We just had enough. It was like, in any case, it was a smaller team that was just like, yeah, all the onc cases.
Did you do well on that one?
Yeah, I got honors.
Okay, good. I feel like the work I did to get honors on my medicine sub-I versus the work you did to get honors on a peds onc sub-I are two very different things.
No, I mean, I mostly just, well, the thing is that I guess the psych thing came in handy. I spent a lot of time just like sitting at bedsides. So, because like, what can I do? Literally, there's not much I can
It's mostly
do.
just like about reading up on stuff and like answering all the pimp questions correctly. Because that's how you get evaluated nowadays.
Yeah. Fever of unknown origin. That's what I had to present on. I remember because I have nightmares about it still.
Oh my god. What a dumb period.
Alright. We should both go.
We should go. It's been like 2 hours.
Yeah,
let's
this is
get
long
out
enough.
of here.
Raid? Yes? No?
Yeah.
Who
do you have?
I have my friends.
Okay, we can raid your friends. I don't.
Oh, if we want to keep the theming, Adir is streaming Helldivers.
Yeah, that's totally theming right there.
Well, no, but she's a doctor.
That is true.
Are there any other medical people? Are there any other medical people you know? I just think it's funny. I guess Adir is, yeah, why not? She's doing her weekly Helldiver streams. Whenever I see her streaming Helldivers, I'm always like, bro, why? Why is this your hobby?
I know. Thanks for the fun psychiatry conversation. Thanks guys for stopping by.
Yeah, thank you guys for stopping by.
I learned so much.
Yeah, this was so much fun. I was actually like really nervous, but also very excited. I always try to tell myself, I'm not anxious, I'm just excited. So I was very excited. And
yeah, and then I was like, why are you nervous? I'm answering the psych questions. It's not like I'm making you answer the internal medicine questions.
I know, I just... Well, you could make me answer internal medicine questions.
I totally should. That'd be hilarious.
Actually, yeah, we should do it the other way around if you still have
that sounds mean. I don't have access. I mean, I guess we can do like the free ones maybe.
Yeah. But okay, sounds good. We should do this again sometime. It was a lot of fun.
Yeah.
I'm always available. Blah, 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 blah. Thank you so much for doing this with me.
Problem.
Okay, and
let's
gonna auto raid out
go
soon.
to the endings and get out of here.
Okay, boy.
All right. Goodbye, everyone.